Now, next topic, period pain. I have this adage that period pain is not normal if it affects your quality of life once again. So it's the commonest cause of pelvic pain. And what happens is that the uterine muscle contracts, and when it contracts, it actually blocks the blood vessels, and so that leads to what we call ischemia, and it's that causes the pain, not just the actual cramp. And it can be lower abdominal, can be on one side or the other, it can be in the back, it can radiate down the legs. It can be in the back passage as well. And women who have period pain often feel nauseated, they feel dizzy, they look pale, and they can have diarrhea or loose bowels and vomiting. We often see this in the first few years when the cycle is trying to get into a regular pattern, but then we also see it in other conditions. So it's not normal if it's increasing in its intensity, if it's not being controlled by simple analgesia, and if it's impacting on quality of life. So the young woman who has to be picked up from school or can't go to school, the young woman who's studying and can't attend her lectures, or actually is unable to work or has to come home from work, that is not normal and help should be sought. So one of the things with the period pain that is most important to exclude is in fact endometriosis. And there's a lot about endometriosis on the Jean Howes website. So it's a diagnosis that has to be made by laparoscopy, but it's important if period pain is impacting on quality of life, please seek help. Now, what about PMS? So when I was involved with setting up what was called the Menstrual and Menopause Clinic at the old Queen Vic Hospital in Melbourne in 1982. And at that stage, we had about 80% of the population of our clinic were women with severe premenstrual symptoms, and 20% were menopause symptoms. Now in our clinic, we would occasionally see somebody who has premenstrual symptoms, and the number of women I see in private practice also has diminished. But majority of women will have some symptoms premenstrually, but it can be mild, moderate, or it can be severe, and it's probably due to a very complex interaction of neurochemicals and progesterone. Because if women don't ovulate, they don't actually have PMS. So about 75% will have mild symptoms, 20 to 30% will have severe symptoms, and there should be a period of time either starting during the period or in the week after where there are no symptoms at all. And there are many different symptoms. The most common one is irritability. So there are the mood changes, there are the physical changes such as bloating, there are symptoms such as acne, also sleep disturbance. Some people have loss of libido, and a very small percentage of women have an increase in libido. There are also food cravings, the Tim Tam time, and premenstrual headaches. However, there is a disorder that has been also termed by the Americans premenstrual dysphoric disorder, which represents the severest form of PMS, where the symptoms are so severe as to really be debilitating and interfere with daily life. But luckily only a small percentage of women, between 3 and 8%, have PMDD. So what about the management? Well, it's pretty tricky with that lady, but being aware of what happens in the premenstrual period, for some women that was enough to be able to make some strategic changes in their lifestyle at that time, where they made life calmer, where they tried not to be stressed out. They may have had some CBT or something like that. But charting the symptoms is often a very good way of being able to see exactly what happens, because often it's a sort of diagnosis after the fact. The period starts and then the woman says, oh, now I know why I was feeling like this. So it's a good idea to do that. It's a good idea to try and avoid all those sweets that one likes and to try and increase the phytoestrogens in our diet and to increase our exercise, which is often the least thing we want to do premenstrually. I did have one patient who used to manage her PMS by doing 3 hours of exercise every day in the premenstrual period. That's a bit of an exaggeration. But in fact, it did fix her symptoms because of the endorphins that were stimulated by that long time of exercise. But what do we use as medical practitioners? Well, there is very good studies that have gone back to the 1990s where the use of Lovan or Prozac has been shown to be very effective in reducing PMS symptoms. Only a very low dose, and literature in the last 10 years has shown that we can just give it cyclically during the premenstrual time. So it's not an antidepressant dose and it can work very effectively. And of course the oral contraceptive pill, the one that has been trialled and has an indication with the TGA in Canberra is Yaz, that has been in the limelight in recent times. But stopping ovulation is one of the ways of effectively treating PMS. So there are some newer research going on at the moment, but at the moment these are the medications that we would use.